And it's my pleasure because I got into medicine to serve. And whatever success I've had financially or academically or professionally is a side story. I actually wanted to be a physician to make a change for my community. So I'm happy to contribute. The title is a little bit robust for 10 minutes. What every cardiologist in 2019 needs to know about cardiometabolic risk reduction in diabetes. I'll just hit some high points and then we'll have a panel discussion. How about that? If you look at my title, I'm an endowed chair in preventive cardiology at Tulane, my hometown of New Orleans, named after Gerald S. Barron, who recently passed. And those of you who don't recall, when I tell you may remember, he pioneered the idea that cardiometabolic risk starts in childhood. He had the Bogalusa Heart Study, a biracial community in Bogalusa, Louisiana, a small town north of New Orleans. And at that time, we thought these diseases just flourished in adulthood out of nowhere. But he showed that diabetes, hypertension, even atherosclerosis started in youth. That's Gerald Berenson. Here are my disclosures. I'm not really talking about any drugs or anything related to any product. So diabetes is important. It may not be a coronary heart disease risk equivalent for everyone. A young person who consumes too much refined carbohydrates and is not active and has obesity, has diabetes, doesn't really have the same risk as someone who's had a heart attack. But after about 10 years, and especially in middle-aged and older persons, the risk of diabetes manifests itself. The statistics are all there, 2 to 4 times heart disease rates, increase in death, stroke, increase in heart failure, which we now starting to recognize that diabetes with or without coronary artery disease can cause heart failure. And the last bullet point, an actual shortening of the lifespan. Persons with diabetes don't live as long. These are the bar graphs. The color code, non-Hispanic black or African Americans in the red, Hispanics in the green, Asian in the purple, non-Hispanic whites in the blue. There's a disparity in physician-diagnosed diabetes. And if you have undiagnosed diabetes, disparity persists. Now, I don't think that there's one gene that explains this across all of these different racial ethnic groups. It's probably related to lifestyle, adverse lifestyle, socioeconomic status, health-seeking behavior, etc. But non-Hispanic blacks and Hispanics clearly have higher rates of diabetes. Hypertension. Hypertension is not a bystander. In fact, across the globe, I just came from India, Nepal, and Myanmar. Hypertension is the most powerful risk factor for cardiovascular disease, including heart attack, stroke, and even heart failure. And here you see the color code has changed a little bit, non-Hispanic whites in the blue, and the various minority racial ethnic groups are in the light blue, green, and very light green. And you see none of those groups have the same rates of control. Now, if you tease this out a little bit more, the persons in our society who have the worst control are people who don't have insurance. Having identifiable source of primary care, appropriate referral to specialists, living in a stable socioeconomic environment, those are the predictors of doing well. If you don't have that, you do poorly. And in fact, one of the things I often say is that this whole idea in terms of disparities, both related to sex, gender, race, ethnicity, social class, et cetera, that's not a by story. I mean, that is the story of the American healthcare landscape. It is the reason why politicians inappropriately say we spend more per dollar on healthcare, but we have a life expectancy that's only 16th among developed societies. That's not true. If you have means, if you have insurance, if you live in a stable environment, if you get appropriate care, you live just as good as someone in Japan, Western Europe. So the disparities actually defines the healthcare landscape. Here's a bar graph looking across several years, and I bring your attention all the way to the end. And you see those persons who have diabetes, when you look at all the various risk factors, A1C less than 70, blood pressure less than 130/80, LDL less than 100, very few will reach those landmarks. Furthermore, we as cardiologists need to embrace this because there's just not enough endocrinologists to go around. Of course, the primary care providers, the internists, family medicine docs, the nurse practitioners, the PAs, they're the real front line. But if you're looking at specialty care in these very high-risk patients, this is recent data that was reported from Yale, looking at persons with diabetes almost 80,000 persons, they were 3 times more likely to see a cardiologist than an endocrinologist. Of the million doctors in the United States, you have about 34,000 cardiologists. You only have about 7,000 to 8,000 endocrinologists. So we're going to have to embrace this burden of cardiovascular disease associated with cardiometabolic disease and diabetes, because you just don't have enough endocrinologists to do that job. If a person has type 2 diabetes and cardiovascular disease, there's 5 times more likely that they're going to see a cardiologist than an endocrinologist. And again, heart failure raises its ugly head as a risk factor. Now, I just changed the citation on this. You can look at the bottom. There are 2 citations. One is the 2018 ACC Consensus Expert Pathway, not a guideline. It takes 3 or 4 years for guidelines to catch up with outcomes data. And the other is an ADA EASD report, also 2018, published in Diabetes Care. And both say the same thing. If a person has diabetes and has associated cardiovascular disease, there are really no data that oral sulfonylureas do anything. In fact, I don't think they will get approved today. There's very little data that tight control using insulin improves macrovascular disease, but there's increasing data for kidney disease with SGLT2 inhibitors, heart disease with SGLT2 inhibitors, overall atherosclerosis with the GLP-1 agonist, that these drugs can be life-saving. They're costly, so access then becomes a barrier. What the guidelines suggest then, in patients who have atherosclerotic cardiovascular disease, again, not guidelines, the report, they're not full guidelines. If they're at risk for heart failure, you should consider an SGLT2 inhibitor. If they're at risk for chronic kidney disease, consider an SGLT2 inhibitor. And on the other side, mainly for atherosclerosis, consider a GLP-1 agonist, which also help with weight loss. Now, one thing I don't have in this slide discussion, and I'll do it in our panel discussion, is tell you a little bit about some of my experience in a recent Circulation published article that we did with empagliflozin in African Americans who had hypertension and diabetes, and I'll tell you the outcomes when we sit down. So I kept it on time. I believe in starting on time, staying on time. Cheryl knows that this is something that she feels is very important in our meetings at the ABC, so I'm going to adhere to that. Thank you.
I wanted to ask you, so there aren't new guidelines yet on this. That's actually what a payer will wait for before making a difference in how the tiering on a formulary for different treatments. What do we, as the academic organizations, if you will, what role do we play in making sure that when we see consensus statements, we're able to form a good quorum and approach this discussion from, no, the data's here, but we've got frankly, an old process of taking 3 years to do a guideline. How do you address that? I say that because Keith writes a lot of guidelines.
Right. I have been on the guideline committees, many of the JNC, blood pressure, I was one of the chairs. The problem with guidelines is that they're slow, very slow moving. And if you wait for full guidelines before you change your practice, then you're going to have patients who have died inappropriately over those. Census reports are kind of a speed pathway to get to that particular pathway. In reality, if you look at, and I said a lot, less than 10 minutes, but if you look at sulfonylureas and you look at some of the older studies, they really may actually increase cardiovascular risk and clearly don't help. If you look at the Origin trial with tight control with insulin, or if you look at ACCORD in those patients in the VA study with insulin, very tight control with insulin may help microvascular disease retinopathy, doesn't help, and may increase cardiac death because of the risk of hypoglycemia and hypokalemia associated with that. So it doesn't make sense for me as a clinician who's seen thousands of patients to sit idly by and wait for the magic guideline before I embrace the cardiovascular outcomes trials with the SGLT2 inhibitors and the GLP-1 agonists, along with the renal trials. We know one with canagliflozin and cretins just showed that it decreases progression to end-stage renal disease and cardiovascular death. It just doesn't make sense as a physician to wait till we have the magic guideline before I make decisions on that. I also made, in my very brief but densely packed comment, something about empagliflozin, which is an SGLT2 inhibitor. And in that particular study, we took 150 African Americans who were high risk, and we placed them on placebo versus empagliflozin using ambulatory blood pressure monitoring, which is the gold standard, decreased 24-hour ambulatory blood pressure, systolic pressure, 10.3 millimeters of mercury, placebo contracted 8.5. So an ABPM of 8.5, placebo subtracted is about 12, 14 points. The drugs lose weight because you urinate out excess calories, you lose sodium and water. They may have some effects on the endothelium, and they may have some effects in making more available energy to the heart. So that's a long way to say the following. I think we need to figure out how we can use newer therapies, how we can remove barriers to access and cost, how we can ensure that regardless of a person's race, ethnicity, sex, gender, social class, or geography, they have access to the new medicines.
Thank you. And I'm going to go back, so focusing on women and minorities a little bit. Because we just talked about access issues, we talked about cost issues, and so you may have an African American or a Latino patient who, when you see them, that's when you see them. Or for a woman who's multi-juggling, as we call it in my home. When you see a woman or a minority patient, how are you guys taking that into account in the practice of, are we treating them recognizing some of the social determinants as well? Or are we kind of, nope, the guidelines said this is when we'll do it. How is your care changing to take into account real life factors? Stacey?
No patient who sits in front of you is a patient who's on a guideline paper or on any of our. So, it starts, and we all have the same time constraints, the 20-minute visit, the issues of charting. But asking questions like, what's important to you? How did you get here today? Identifying ways to meet people where they live, accepting better and not perfect. Tell me what you want to address first. Is it weight management? Is it this? Because we can send someone out with 8 prescriptions, as you said, for a multitude of reasons, most of which patients are embarrassed to discuss with us unless we make it, an open environment. We don't get the outcome. So for women, it's acknowledging the societal issues that women put everybody first, that they'll feed and get appointments for everyone before themselves. Complexities of how medications are taken, how much literacy of health and numeracy is there, and to not make assumptions. And then finally, to set up systems that work. And I think the beauty of preventive cardiology taking the forefront now is that no clinician knows that it's all about them and their practice. It's about setting up systems to optimize the outcomes.
Isha?
Yeah, I agree with everything that Dr. Rosen had just said about women, but also, we know that the minority patients that, because for a number of reasons, African Americans, Hispanics, because of socioeconomic factors or because of biology itself, have worse outcomes with a given disease condition. So I think that the onus is on us to be as aggressive as possible in medications and in referrals to therapies and referrals to specialists, especially in those patients, simply because their outcomes are worse.
And I'm going to ask you a different, do you check formularies of your patients based on their insurance before you prescribe? And is your EMR optimized to do that for you? How is technology helping us, right? So we have gender information, we have race and ethnicity information, and you can, depending on what software you're using, pre-populate. How are we using that to help particularly this population?
I would love Vic did that for me. And if someone's figured that out, please.
Epic's probably our next sponsor.
Come be my friend. So usually it's trial after a few prescriptions is how I figure this out. But it takes time. It's like the kind of thing, again, where you need to want to learn. After a few times, I'll start to figure out, what the rules are for different payers. everything. But I know it's best for my patient, so I keep trying until I get something or figure out what it was that I needed to document. And that's where I find other colleagues very helpful. And really teams. I mean, it all comes back to teams, because this is you learn with a team. So, advanced practice nurses, diabetologists, but I find that that's the way to figure this out.
And Keith, separate question for you. How do we get information out to cardiology about treating cardiometabolic? And so that's one piece. And then how do we make sure that patients know how to ask when they come in?
All right.
And what are your best practices that
I shall make a humorous note before I answer those two questions. Every time you try to formulate a question that you think is coming your way, you change the question.
Thank you, everyone.
That's the way she does it. All right. Getting information out is doing what we're doing now. Those of us who perceive that we have a job of teaching and leading and being thought leaders, we need to make sure that we're at the table and we make messages that are accessible to our other practicing clinicians, whether they be specialists or not specialists. So one of the reasons I was happy to come way up here and fly and get in late at night and come home in the morning was because I believe that this is important. We need to help our brothers and sisters who are treating these patients. The second one, in terms of the patients, one thing that I do on a regular basis, and I cut my teeth in the Ninth Ward. I had a practice, cardiovascular center. I was an authorized user, nuclear medicine specialist. You could park your car, walk in. We didn't have guards and elevators. Wasn't security. It was right, boom, right there on the street. You want to see Keith? You're in. I always would ask, who brought you today? Who's with you today? And I'm going to take about 3 minutes because I think this is really important. Some of the young doctors, the fellows, the residents, and even the medical students love HIPAA because it allows them to say, well, I didn't talk to their mom. I didn't talk to the cousin because, I didn't get authorization. HIPAA doesn't say you can't talk to them. You just have to take that extra step. And here's the two things I tell them. Number one, the person who brought that person is in the waiting room, and you'll be surprised when you go out and you're dealing with this person with what you've considered illiterate or doesn't really articulate well, or English is a second language. They could be a nurse, they could be an accountant, they could be a teacher, they could be someone who works for the government who happened to have brought mama or daddy to the clinic that day, and they can really help you in the practice. Number two, you can make all of these great recommendations, SGLT2 inhibitors, GLP-1. I want to do intensive LDL reduction, high-dose statins. Now I want to give you this new drug called PCSK9. That person you didn't talk to can destroy your now 25, 30-minute visit by saying, Mama, that's too much medicine. Don't take all that medicine. So bring them into the doctor, patient, family, community treatment, because they can be partners or they can be saboteurs. They can just take all your good work, and you'll find out when the patient comes back, the LDL is still 174 and the blood pressure is 155 over 110, and the A1C, you check it again, it's 9. You say, what happened? Well, my daughter said, don't take all that medicine.
We don't practice without teams. That's exactly. A patient's team is part of everything. Who drives them, who buys their meds, who cooks their food, who helps them translate if there's English language issues. Their team.